Yep. Hello, everyone. This is Caleb Banta-Green at the Alcohol and Drug Abuse Institute. Thank you very much for joining the webinar. Very excited to have you here today. My sort of co-moderator presenter, Allison Newman, is not able to join us, so I will be driving this and moderating myself. Today's topic is overdose follow-up interventions, sort of after naloxone, what's next. And just to share with you the format for this is I'll give a bit of an introduction. We have 3 presenters who are each going to talk for about 10 minutes. And we're happy to take questions sort of along the way via the chat function of this meeting. So just go ahead and type in your questions and we'll be tracking those and we'll be answering those questions at the end. We have the audio is muted for the participants given the large number of participants we have. So we're going to need to have your comments via chat and questions. And then we'll just move through this, and we have just a little less than an hour. We'll be wrapping up at 3. This audio is being recorded. The whole function is being recorded, so you'll be able to look at this later if you want, and we're happy to share the slides later as well. So just to share with you that this webinar is funded through a contract we have with the Washington State Division of Behavioral Health and Recovery. We thank them very much for that. We're in the 4th year of a 5-year project around opioid safety, so this is an important component of that. And really important, the information is not for legal or medical advice. This is just for educational purposes. And then I'll be moderating today. My name is Caleb Banta-Green. I'm a principal research scientist here at the Alcohol and Drug Abuse Institute. I'm also a professor in the School of Public Health, and I do a whole range of things in terms of research and implementation support related primarily to opioid misuse, use disorder, and overdose. And my colleague Allison Newman is a continuing education specialist working with me on this project, and she unfortunately was called away rather urgently and is not able to join us, but I know I'm very excited about this work and has done a fabulous job putting all the materials together. So the goal today is to introduce this topic of overdose follow-up interventions and provide examples from Washington State. I want to be really clear, we are not going to cover everything. We're not going to get into a lot of detail. Our main goal today is just to sort of pique people's interests and to really get a dialogue started. And if people have questions that we can, if we're not able to wrap up today, we will definitely happy to follow up with the participant list here and figure out how we can get all those questions answered for you. So again, our goal here is to start the conversation. So here we have, and I think the slides may not be keeping up here right now, so I'm going to go ahead and just describe them well. So be really clear, when we're talking about overdose and follow-up interventions, naloxone is an overdose antidote as an emergency rescue medication. It only lasts for 30 to 90 minutes. It is a really proven effective intervention, and we know that it works very well, but we also know that it's not a complete solution to dealing with overdose all by itself. We know that people can benefit from strategies to reduce their own overdose risk, and we also want to be able to connect them to treatment and other resources with the goal of improving their overall health and well-being. So naloxone has a significant impact, statistically significant impact, and certainly a very significant impact for the person whose life is saved and for their family and friends. We know from a public health perspective that the impact at the population level is about a 6% reduction in mortality across the lifespan. So it's a very important intervention. But distributing naloxone primarily to heroin users, we know the best evidence we have is it reduces mortality rate at the population level about 6%. That's important and significant, but it is clearly not enough by itself. We know that longer term, treating this as a chronic medical condition, not just an acute episode, medications, buprenorphine and methadone in particular, they reduce the chance of death from overdose by 50%. And then another medication, long-acting naltrexone, has mortality reduction impacts as well, but we just have far less research on naltrexone at this point. But as an opiate antagonist, we know that it also has, a long-acting opiate antagonist has life-saving impacts as well. So I'm going to pause the audio for just a second. We're taking care of one technical thing on our end. Okay, we're back. Sorry for that. Just to share with you, as I mentioned, so our goal is to sort of go over this topic of overdose. I'm going to give a brief overview of data around overdose in Washington, talk about what do we mean by overdose follow-ups. We're going to get 3 examples from colleagues, David Doran from Clallam County, Kurt Gordon from Tacoma, and Dave Gardner from Mason County. And again, we'll have some opportunity at the end to have some discussion via the chat functions. As I mentioned already, naloxone is a very important acute rescue medication, but it's brief and its effects are modest. There are other options in terms of longer-term managing opiate use disorder as a driving condition for many folks who have overdose, and we'll be discussing those as well. So just to share with you, syringe exchange survey results from last year. These data are online on our webpage, on ADAI's webpage. We asked folks, how interested are you in reducing or stopping your opioid use? And then what you can see here is 72% said they were somewhat very interested in stopping or reducing their use, and most folks said they were interested in methadone or buprenorphine. And we're getting a couple of questions about folks saying they don't have sound. We are not set up with a phone number. This is set up for Adobe Connect with sound via the web interface. Also from the same syringe exchange survey, among those who used opioids in the last year, 19% or 1 in 5 had an overdose, 60% had used an emergency department, over 40% had been in jail or prison, 48% had been in some sort of treatment or social support, and almost a third had received treatment medications. And so these are an indication that people are reaching out and trying to get help, and also identify opportunities and locations of where we can be engaging with folks. So we really want to work with community stakeholders to identify appropriate resources and referrals for overdose follow-up and identify what types of providers should be involved and bring them together. And you can see this long list of folks. You probably can think of other people as well. And it's really important to get these people engaged at the front end and in an ongoing way. Don't worry, this is not a test. This is just to give you a sense of there's a really big toolbox when we're talking about things that include prevention. We're talking about the populations, interventions, and care settings. We're talking about treating opioid use disorder and or managing pain and opioids well, thinking about, again, these different characteristics. And then also just trying to keep people alive, which is what we're focusing on today, improving functioning, reducing mortality, including overdose and infectious disease, with the idea that a lot of the services that we do over here are also, in terms of treatment, are also helping reduce morbidity and mortality. We want to help people get to the next step in their health and safety. So it might start with a naloxone kit and overdose education, but then move on into syringe exchange and clean injection supplies, looking at treatment medications, methadone, buprenorphine, or naltrexone, along with appropriate counseling and social supports. Of course, looking at primary health care and housing and other social services. Really importantly, it doesn't have to go in this order, right? We have a housing first model in Seattle. Getting a person housed is going to bring a lot of stability to them so they can attend to the other areas of their life, just as getting treatment medications or good stable health care can also help a person have some stable foundation from which to begin to work on other aspects of their life. A couple national examples I'll just mention. In Rhode Island, there's a program there with a peer recovery coach visiting someone in the ER or at home after an overdose. In Illinois, enhanced strategies for first responders and law enforcement to make referrals to treatment and support. And in Boston, an overdose team approach, and that's about connecting people to care, harm reduction services, and referrals. So there's some nice national examples to draw upon as well. So I would like to turn this over to David, who I'm going to have give me a call on my phone now and put his audio through that way. So that'll take just a second while he calls me. So hang on a sec. You there, David?
Yeah, I am.
Great. Go ahead. We can hear you.
Okay. So in Clallam County, I'm getting some feedback there. So in Clallam County, we started to make opioid overdoses a notifiable condition condition in 2016. And so what that means is that when somebody overdoses, we do a case just like if somebody has chlamydia or giardia, we do a case on it. We call the person up, and we try to get them in for naloxone. We try to get them in for treatment and find out what they overdosed on, whether or not if it was prescription medication or if it was heroin. If they have a provider, we notify their provider that they overdosed. And we keep track of like what city they overdosed in Clallam County, and what they overdosed on, and just a bunch of other data on them. We started doing we have the PMP, so we can look up and see if they're doctor hunting, if they're getting their prescription medication from other providers, and then notifying those providers as well. Any questions about this so far?
So, David, we're going to save the questions for the end, so if you don't mind, keep going, it's fine.
Okay. So in 2016, we had 63 overdoses and 6 deaths. And the age was, the most common age for overdoses was 20 to 29 in 2016. 38% of the people were members of the syringe exchange in Clallam County, and 62% were non-members. 69% overdosed on heroin, and 29% overdosed on prescription medication. In 2017, we got to look at the data and compare it, and there were 31 overdoses in 2017. The common age was 30 to 39 in 2017. There were 7 opioid overdose deaths, and
David, do you need me to move the slides at all for you?
yeah, go ahead and move them.
Okay, do you want me to go here or a little further?
No, that's fine right there is.
Okay.
So this is, on this slide right here is what an opioid overdose case report looks like. So we would like to see everybody doing opioid overdoses in Washington State, making it a case report. What our local hospitals, the Forks Hospital and Olympic Medical Center in Port Angeles and the coroner, that's where our cases, that's where they come from. So this is what a case report looks like. We'll get these facts to us from the local hospital. And the biggest challenge is trying to find a IV drug user after they've overdosed. A lot of them, they'll just leave the hospital. So what I would like to see is that we could go into the hospital and give the people naloxone before they leave the hospital and hook them up with treatment at the same time.
David, one sec. Can you turn down the speakers in your office, please? We're hearing a lot of feedback.
Okay.
And then you can just talk, and I can hear you.
Okay, how's that? Is that better?
I think it's better. We'll find out as people let us know, but I think that's fine.
Okay. All right. And so this is what an opioid overdose case looks like. A lot of times they won't do a talk screen, and so then it's the case is probable. We've been entering the cases into FIMS under other condition, and I'll put them as a opioid overdose.
Okay.
Well, what's really exciting is that they've decreased over 50%. The opioid overdoses have decreased 50% in Clallam County since we started doing that. I don't know if it's because it's probably because that we've given out a lot of naloxone. People are still probably overdosing, but they're just not being seen in the hospital as much. You want to go to the next slide? So this is an authorization form to give us permission to, when the person overdoses, to that somebody from a treatment facility can call them up. And we were working with Peninsula Behavioral Health. They were the CDPs that were contacting the people. Currently, we don't have a CDP working for Clallam County. And it was really a good deal working with them because the CDP that we had, she was working in the Clallam County jail as well. And that's bringing up the jail. That's another way that, you know, I'll find the people that have overdosed is I'll look at the jail roster, and a lot of times they'll show up in the jail. And the most vulnerable time for an IV drug user who uses heroin is when they get out of jail, because they'll go right back to their regular dose and they'll overdose. And so I've trained the jail nurses how to teach people how to use naloxone, and I'll bring naloxone over there if there's a overdose case in the jail. This right here is a letter that we'll send out to the provider, letting them know that they had a patient that had overdosed on opioids, whether it be on prescription or heroin. A lot of the heroin addicts, they don't have providers, but the people that overdose on prescription medication, they will have a provider. The people that I've contacted that have overdosed, it's been positive. I haven't had people that were upset at me that I've contacted them and let them know, you know, that the drug that saved their life was naloxone, and I just want to get them some naloxone. This slide right here is the Clallam County Opioid Surveillance Dashboard. And I can't think of anything else to say. Thank you.
Okay, great. Thank you, David. All right, Kurt.
All right, thanks for having me.
Yeah, I can hear you.
Is the slide advancing on your end?
Yep, perfect. Thank you.
Okay, well, my name is Kurt Gordon. I work with Tacoma Fire Department. I've been here 17 years, and 9 of them have been as a firefighter paramedic. We just recently launched a naloxone leave-behind program, and we're also partnering with the Pierce County Jail to try and get naloxone kits to inmates that are going to be released or part of their education program. So if you want to reach me, there's information there. And just a little bit of background about Tacoma Fire Department. We cover 72 square miles, about 225,000 citizens in our area. We've got 5 medic units. Each medic unit has 2 paramedics and also 3 ALS engines, which are staffed with 2 firefighter EMTs and 1 firefighter paramedic. And BLS crews, basic life support crews, we have 17 engine and ladder companies. Last year, we had 38,000 medical calls thereabouts, and we suspect about 282 opioid-related calls over the last 2 years. So part of the naloxone leave behind program, this is what the kit looks like. We partnered with Point Defiance AIDS Project, who is the hub for this area, to do naloxone through the SAMHSA grant. We launched it the program launched about a week and a half ago, and we anticipate giving 15 kits out per month. And the idea with the kit is to have it be a follow-up mechanism. After we've resuscitated the patient, we give them the option to have this kit. And part of the option is to kind of tie into our TFD Cares program, which is what we're going to focus on for this presentation. So the nice thing about this kit is it's very slim. The Naloxone, the nasal Narcan box is pretty bulky, and I think probably hard to keep with you in a purse or a backpack. And we can modify the contents of the kit based on what's working, what isn't working, and what feedback we get from our patients. So kind of a blown up shot of the different contents using stopoverdose.org's info sheets. You got the 2 doses of nasal Narcan and a phone number for PDAP, or Point Defiance AIDS Project, to get a refill. The thing we didn't want to have happen is them calling 911 to get a refill. And the other piece of it is the phone number for TFD Cares. So TFD Cares. It is the abbreviation, let's start with that, Tacoma Fire Department, Community Assistance, Referral, Education, and Service. And I think what's special about this program is it is managed by our nurse managers. We have RNs and recognized community healthcare workers that are staffed by the City of Tacoma, Tacoma Fire Department, and they can do follow-up care for our patients in a non-emergent setting. So what exactly does that look like? Their coordination of care is their goal, to connect them to needed services, and 3 major categories, which this slide doesn't represent well, but physical health, mental health and well-being, and social health, covering chronic illnesses, pharmacy services, all types of substance abuse disorder. If they need help with food, transportation, and all this work is done at this point. It's all done telephonically. And in last year, TFD Cares reduced ED use by 94% for individual users. So that's a huge byproduct for our local hospitals and emergency departments, keeping people out of the hospital when they just need a pharmacy refill, or they just don't feel well in general. They call the FD Cares line, and they can get non-emergent medical help, and we can get them tied into a primary care provider or the appropriate destination for the help that they need. 38% increase of referrals from the previous year. That's from our own fire department folks. Police department also is tied into our system. People walking into fire stations or into our headquarters, they can get referred to the FD Cares system. And another byproduct of the program is a reduction in 911 EMS calls of 97%, which is pretty significant. So what does it look like after we've resuscitated the OD patient? They have the choice to opt into the program, and what's nice about it is it's electronic, it's real time, so all of our patient care reporting is electronic, and once they've signed and we hit the send button, it's uploaded to our server, and our TFD Cares folks have the information right away. And all the patient has to provide us really is a phone number for us to follow up with, and the signature kind of opting into the program. And our goal is to get in contact with them within 24 to 72 hours. And the reason there's a longer period on the back half is really if they call, if the event happens late on a Friday night, the TFD Cares, they don't work over the weekend. They're kind of a Monday through Friday setup. So in most cases, we'll be able to call them on the next day unless it's over the weekend. So while they're on the phone with the patient, we can identify all their health needs and wants through a couple surveys and questioning, and we can offer them access to detox, inpatient, outpatient, MAT referral, and whatever other services they might need. What's nice is it's not a one-way system. We don't just call them and they're able to call us if they need any kind of help, or they need someone to talk to. And they can call our nurses at the TFD Cares line and talk to someone. And it's right there on the Naloxone kit. They don't have to remember it. They don't have to put it in their phone. They have the kit with them. They have the phone number. And again, everything's done telephonically. And the kit really for us is the mechanism to start the conversation and connect the patient to whatever that next step is for them to help them stop using. And that's the kind of the heart of TFD Cares. So I think this is kind of my wrap-up slide on my thoughts on getting started with the Naloxone Leave Behind program. And in general philosophy for us at TFD is, we're starting with a new project, a pilot project. We just want to get started and see how it's going to work, and even if it's just a small start, and we're agile. So if it's not going well, we can readdress whatever's not working and modify it. Does the kit need more information, less information, clearer signage? Currently, we have the kits on our 5 medic units because these are the rigs that will be on scene for the opioid overdose. So at this point, we just have the 5 spots. Is that the right distribution model? Do we want to distribute from fire stations? Do we want to do needle exchange at fire stations? These are all questions that we're asking ourselves, and what is the best practice and trend in working with our community partners. Other things that we've thought about doing, using mail bags from Pierce County Health Department for collecting unused medications. What about mobile MAT? And I think what's been key for this program to get off the ground is networking, collaborating with area partners. Obviously, ADAI and PDAP have been really strong partners in making this work. And that wraps up my presentation.
Great, thank you so much, Kurt. And just to be clear that for folks, that MAT is medication-assisted treatment. So we usually think of those as opioid use disorder treatment medications like the 3 I mentioned earlier. So Abe, please take it away.
Excellent. Thank you, Caleb. All right. Good afternoon. My name is Abe Gardner. I work for Mason County Public Health and Human Services as a community health program assistant and peer recovery and prevention specialist. I was hired to work as a part of Mason County's overdose prevention project on March 1st of 2017. According to a 2016 census, Mason County had a population of 61,060. Our opioid-related death rates between the years of 2012 and 2016 were 14.7 per 100,000, the second highest county rate in the state during that time period. Mason County's opioid response plan aligns with the response plan of Washington State. Our overarching goal is to eliminate overdose deaths through prevention, access to treatment, reducing deaths, and by using data wisely. Our overdose prevention project is focusing most intently on the 3rd component, reducing deaths, while affecting and impacting the other 3 components as well. A specific area that we are putting energy into through the efforts of our overdose prevention project is the opportunity to provide community workshops that increase awareness and education in regards to opioids, overdose, and naloxone. We are somewhat unique in comparison to other counties that have similar programs in that we don't have a syringe exchange, thus lacking a central location for folks to meet. We have worked with community partners to establish several consistent and accessible locations where we are able to hold workshops for groups of people as well as individuals. Another focus of our project is the gathering of important and pertinent data. Dr. Diana Yu, Mason County's health officer, made opioid overdose reportable in 2016. This obligates the hospital community to report overdose, although it does not obligate first responders. With some hard work, coupled with some willing community partners, we are now receiving reports from not only our local hospital, Mason General, but our community's first responders as well, including North Mason Regional Fire Authority, Shelton's Police Department, and our Mason County Sheriff's Office. So, we are now able to capture data from overdose situations that may not make it all the way to the local emergency rooms, as well as have the ability to reach out to those survivors. When an overdose occurs, the health department receives a faxed report from either the hospital or the first responder. If the overdose survivor decides not to be transported to the hospital, we receive a report directly from the agency that their first responder works for. We are currently developing literature for first responders to hand directly to an overdose survivor, their family, or their friends that will contain Mason County specific recovery resources, harm reduction tools, and contact info for our prevention program assistant. After we receive an overdose report via fax, they go straight to our public health nurse. Our nurse then gathers as much information as possible. So when we make a follow-up call with the survivor, we can be mindful and sensitive to the details of their situation. Our prevention program assistant then attempts to make direct contact with the survivor through the means of a call or text. Our goal is to contact each survivor within a 24 to 48 hour period following an overdose situation. However, each follow-up is dictated by what information our nurse is able to gather, in addition to what is on the faxed report. Our prevention program assistant approaches each case with the goal to provide immediate harm reduction resources as well as an empathetic ear, with the hope of building immediate trust so as to develop a relationship that can be utilized for the survivor's benefit. We have had some success to date, but we are hoping to improve upon our ability to connect directly with overdose survivors. Some of our difficulties and biggest challenges have included the ability to standardize an overdose reporting process. However, we believe with the help and willingness of our community partners, we are heading in the right direction. At the beginning of the program, we had the challenge of finding a consistent central location for our educational workshops and naloxone distribution. Again, with the help and willingness of our community partners, we are now able to provide weekly and monthly workshops at various locations in our community. For example, we have monthly workshops at Community Lifeline, our local provider of homeless services, weekly workshops at Mason Transit Center in downtown Shelton, and we have provided multiple on-site workshops at other local agencies. Overdose follow-up has also been difficult. Each individual situation differs, and they each provide their own unique challenges. We are constantly working to find the most efficient and helpful way to follow up with survivors. Receiving overdose reports from our first responders was also a challenge. However, we are now currently receiving reports from a majority of our first responders, with plans in place to potentially receive reports from all of Mason County's first responders. That concludes my portion of the presentation. If you have any questions or would like clarifications that would be more appropriate on a phone call or direct email, my phone number is 360-427-9670, extension 131, and my email is agardner@co.mason.wa.us. I would like to thank Caleb and Allison for inviting myself and Mason County to participate in this webinar, and I look forward to any questions. Thank you.
Great, thank you so much, Abe. So I'm trying to think, if people go ahead and type in any questions they have, and then also let us know other topics they're interested in. We'd like to follow up on this for sure. I have a couple of initial questions I'd like to ask. For Kurt, can you talk a little bit about how you're using your electronic medical record, your EMS data system, to document overdose and also your follow-up for overdose, including distributing naloxone?
Yeah, so we've got a HIPAA-compliant, secure electronic patient care reporting system. It's called Medusa Siren, and the data that we collect, we're already collecting during a normal patient encounter. So we're collecting the sex of the patient, the ethnicity, and the year of birth, and we're already doing that. So when we've got the patient narrative, all the kind of the background story of our encounter with the patient, and we document giving the opioid kit similar to the way we would document giving naloxone or oxygen or any other medication. And we chose to name that kit, opioid kit, internally, just so we don't mix it up with the actual naloxone that we use, that we get from our pharmacy and we use in reversing the overdose. And another key component with the patient care reporting is, if the patient is awake, alert, oriented, and they really don't want to be transported to the hospital, then we have them sign an AMA against medical advice. Because for most of these patients, for one example was last week, I gave a kit to a gentleman, and bystanders were doing CPR on this guy. And so for a lot of these patients, we do want them to be seen by a doctor in an emergency department, but the reality is they don't want to be inconvenienced. They don't want to go to the emergency department, and so they sign out AMA, and that's at that point when they're signing AMA, we offer them the kit. And whether we transport them to the hospital or not, we still offer them a kit. So they can, if they're going to the hospital for follow-up care, we still give them a kit. Obviously, on the patient example I just gave you, the CPR was inappropriate, but it was by well-meaning bystanders. So, did I answer your question?
Yeah, that's great, Kurt. Thank you. And I'm going to just launch off on that on a couple of follow-up points. So, one is that folks are probably aware that most EMS departments now in Washington State do have electronic medical records. They vary quite a bit in terms of what data elements are collected, which data elements are reported, and how they are reported. There certainly is a goal with Centers for Disease Control project that I'm partnering with the State Department of Health to try to ensure that those data are getting entered in a comprehensive way and submitted to the state. We think those data will be very helpful for folks on the ground. And as an example of some of the data with which I've worked here in the Seattle area, I just want to share with people that I do have an article that I'm very happy to share. We reviewed over 200 opioid overdose cases, and we came up with a protocol for determining whether it was definitely not probable or definitely was an opioid overdose. One of the things I think was really interesting, and we've seen this with a little bit of other research, is about 2/3 of the time naloxone was administered, and this was advanced life support responders. So naloxone only is not a great measure of whether an opiate overdose occurred. As folks may know, that there are a lot of other ways to manage an overdose in terms of respiratory support and ventilations and oxygen that are often used and often used preferentially. So it's important if you're looking at your EMS data to really work with those folks to understand what are their medical procedures and how might that impact what the data look like, and also how might those procedures be changing over time. They may be shifting as there's care being offered somewhere. They may do a different type of transport or transport more or less often, and those could certainly be impacting those data locally. So it's important to understand that those EMS data can be really rich data, but you really need to make sure you're understanding sort of what's being entered and how it's impacted by local protocols. So I think I wanted to also, so we have a question here, and I have a follow-up question here as well. Lisa was asking about a plan for a standardized overdose report form that any other counties could use. To my knowledge, there's not a standardized overdose report form. I think we need to know sort of what setting you're talking about. As I mentioned, just in EMS data systems, there's not a standardized way to report overdoses across all of those different data systems. You're generally going to be trying to look for a combination of were opioids present, were there medical signs indicating a person possibly had an opioid overdose, and also if naloxone was administered, was there a response to naloxone? That is really the differential diagnosis of an opioid overdose as a rapid, within a few minute medical response to naloxone administration. So there are other forms, as you saw, that David had for sort of their purposes around overdose. There's other documentation we're doing with the Naloxone project around how people describe overdose. So it's really going to depend on what your needs and uses are for those overdose data. So Susan's getting clarification on one question. I want to ask Abe a little bit more about I've spent a lot of time in Mason County, and not just fishing. I've also been down there working. And, there's no major urban core. There's several mid-sized small cities spread around. You've talked a little bit about sort of offering services in central places that people can come to. Are there other services or approaches you would suggest for people working in more, if not rural, at least spread out areas?
Yeah, absolutely. Part of the beginnings of our program was a lot of energy was put into establishing trust among some of the smaller populations. Part of some of our research and or trust building activities were simply going to local parks, walking the streets and reaching out to folks. We had made a non-county type business card that just kind of had a stop overdose on it with Community Health Program Assistant's name and contact info, which we've handed out as well to kind of give an idea what the program's about, and try and get the word out there, and kind of so it's not as associated with an official county project per se, to maybe reduce some of those barriers that they might feel in contacting us. But I think that's the main issue, is trying to gain as much trust as possible, and that's kind of how we did it.
Great, thank you. And just to make sure everyone on the call knows that on the webpage stopoverdose.org, we have a lot of printable resources in terms of handouts. You saw some of the materials that our presenters are using. Some of those are on our webpage. And just feel very free to contact us. We're very happy to try to work with you to, if you need to adapt materials to fit your layout or any local resources, those types of things that you want to add onto the cards. We're happy to work with you on that. So please check out the stopoverdose.org. There's a resources page that has all those materials up there. I have a question for Kurt. Question came in: did you encounter any stigma among your staff, among the Tacoma Fire Department personnel, when you proposed this idea? Did you get any sort of pushback on that? And if so, how did you handle it?
Good question. We've got 375 firefighters in Tacoma, and we're not going to be in lockstep in any issue really. But when they report for duty, they've got to put on the hat of being a professional firefighter, paramedic, EMT, whatever their title is, and they'll hand these kits out. I think there's definitely some varying degrees on the how much time they might spend with each patient, and the kind of the attitude in which they deliver the kit. I think what we definitely have in common is that when we signed up to be a firefighter with the City of Tacoma, is that we signed up to help save lives, to make a difference here in the community, and this is a component of doing that. If you've ever witnessed an naloxone resuscitation, opioid resuscitation, it's a pretty impressive sight, and to know that may be able to happen outside our supervision, outside of the 911 system, our people are definitely on board with that.
Great. Kurt, can you talk a little bit more about sort of who you're partnering with? You listed a couple of the organizations. I'm interested in also the role in working with law enforcement and the criminal justice system in terms of coordinating this work, giving them a heads up, collaborating with them. Are there things that have gone well, things that you would approach differently next time? Yeah,
I think it started because we have really good support from our administrative staff. Chief Duggan, he's the head of our fire department. He's in full support of this mission, and partnering with the police department has been it was a little bit slow to get started, but they're looking. They've got a grant to do naloxone administration, and so we're going to partner with them as well. If there's people they encounter and for some reason we weren't activated, they can give them contact info for TFD cares. And so that kind of started with good support here internally, and the department has to make a decision that it is something that they want to take on. If there's a half-hearted approach, then it's difficult to get traction or to get the ability to move forward. So partnering with the jail has been an exciting program. Currently, the plan is, and we're still working on some of the details, but to kind of let the cat out of the bag. At this point, the idea is that we're going to be in Pierce County Jail and talk to every inmate, giving them some naloxone education, what it is, what it isn't, and it's not going to give them any pleasure if they took it for an illicit purpose. Give them education on the Good Samaritan laws and their protections if their friend were to overdose. We really do want them to call 911 and get help. So give them a very brief round of education, and they don't have to listen, but we're thinking probably a 15-20 minute education period to every inmate in the jail every month. And then a more focused education plan is kind of in process, a pilot program with Pierce County Alliance. And that is the agency that delivers the court-mandated or optional opt-in use disorder classes. So the idea there is that we would go in and give the similar education I've already spoke about, the naloxone, what it is, what it isn't, Good Sam law, and things like that. In that specific, more focused setting, probably the class would be a little bit longer, and at the wrap-up of that class, we would give them a naloxone kit.
And just we got a question, Kurt, that I'll answer, which is what happens if you run out of your 15 kits prior to the end of your month? And I think the idea here is we're just piloting this and figuring it out. And so in the interim, we would certainly just go ahead and keep distributing those kits. I think if we started getting to 150 or 1,500 kits a month, we'd have to have another conversation. But
right.
The point right now is to really try to keep those going. And I want to let people know as well on the stopoverdose.org webpage that there are a lot of other places to get naloxone as well that we want to make sure people know about. In the syringe exchange survey, when we've talked with folks, about 85% of people do have insurance, and we actually have a lot of pharmacies that are signed up that have naloxone. I would actually encourage people to go on the webpage, and particularly if you're looking at making some of those referrals, I would call and verify that the pharmacy is aware of the naloxone program and has it on hand. Sometimes if they're a chain pharmacy, they may have been told they're supposed to set it up, but it may not be fully in place, so you just want to verify that. But there are other options as well. Syringe exchange is one. Here's this program, but there are other options as well for people to reach out and try to get naloxone. We're also going to be, I have not seen it yet, but I hear it is Oscar worthy. Tacoma Fire's training video. Kurt has kindly said that we'll be able to put it online, and then folks should be welcome to try to use that and adapt that as they need in the future. So that'll help, we hope, in terms of sort of giving an example, sort of training and rollout. And my sense is that also addressed not just sort of just the facts, but also trying to talk a little bit about really the motivation and intent behind this work. Abe, I have a question for you in terms of when you reach out to someone who survived an overdose, what is their attitude in terms of talking with you, and what questions do they have for you?
Well, so far, when we've been able to connect directly with an overdose survivor, they've been really receptive to the initial phone call. As we've been able to standardize and streamline our the way in which a survivor leaves the hospital, now we've put together kind of a resource guide and some information that the hospital gives them before they leave, as well as a card that has our name and number on it, so that's not a complete cold call, so they kind of know who we are, and so they're not caught off guard. But they've been really receptive, and we, first trying to make sure they're safe, see if they know about resources that are available to them. Surprisingly enough, some people aren't even aware of the resources we have in our own county or own city, so we try to bring them up to speed and offer to make any phone calls or get them connected with phone numbers. At the very least, offer them a naloxone kit. But if we can do all the above, that's the goal. We've had a few people, as well as their families, be interested in kits. The difficulty, of course, is a lot of people are scared when they're in that kind of situation. So the information they do give, either a first responder or the hospital, may not be a correct phone number or may not be a correct name or whatever the case may be. So we're hoping to continue to build trust within the community, let them know we're here to help. We're not here to condemn or criticize, so that people are feeling safe enough to at least take advantage of some of the harm reduction resources that we have available.
That's great, Abe, and I think you bring up a lot of important points, and I think for people to understand it, when you're first piloting this, it's likely to take a while for it to really take off. The lack of trust is really understandable from the perspective of a person using illicit drugs and also having a very stigmatized condition. So it can take some while to build trust with folks. Be really, it's important to be really thoughtful about how you're interacting with folks. Obviously, people want to be non-judgmental and be really positive, because word will spread, positive or negative, through a community very quickly. And so it's important to really be mindful about really having positive interactions with folks. And I think what's exciting, a lot of people are saying, is that whether it's in a jail context or in a community context, that to be engaged with somebody in a positive way really can start, again, building trust and a collaborative relationship instead of the interaction being really antagonistic. You could imagine that if people find out that not only will Tacoma Fire treat you well, but in fact they're willing to engage you and hook you up with services and are even willing to engage and give you naloxone, that people may be more likely to call during an overdose if they hear that this is an agency that really wants to engage with people in a positive way. And then just a question did come up that was answered, but I'll mention it for everyone's sake, that the pharmacies we have online on our webpage, they have something called a collaborative drug therapy agreement in place. And that is just like how I can go into the pharmacy and get a flu vaccine prescribed, dispensed, and administered by a pharmacist directly. The same regulatory process is in place that allows a pharmacist to directly prescribe naloxone. In fact, I bought the very first kit. I forgot that. It has expired. It's been many years. And I was able to walk into a pharmacy and just say, I'm at risk for witnessing an overdose. I'd like to purchase a naloxone kit. And I was able to get training there and be prescribed and dispense that kit and walk out at the same time without having to go see another person, another prescriber for that authorization. So we're wrapping up. I see another question coming in. I'll wait for that for a moment, but I want to also, as we're wrapping up, let people know how to get a hold of us. Again, stopoverdose.org. We have a listserv. We share a lot of information, and you can sign up at info@stopoverdose.org and get added to that. And or you can just directly connect with Allison Newman. That's her email up there. And so let me see what this question is. This will be our last question for Abe. Are you partnering with tribal nations within your county for overdose prevention? And if so, what does that partnership look like?
The answer to that question would be yes. We've reached out to both the Skokomish and Squaxin Island tribes. They've been receptive. We were able to go out in November and do a workshop with the Skokomish tribe where the community was invited, as well as folks at the health clinic, and it was open to anybody. We had a really good response, and we're continuing to work with them insofar as gathering data and just trying to be really sensitive of their needs and making it a true partnership, so that we provide resources and things of that sort that are specific to what their community is looking for. So we look forward to continuing those partnerships as well, and the Squaxin Island tribe is also interested in us having a workshop out there. We were able to supply the tribal police out at Skokomish with naloxone, so they all had naloxone. It ended up being expired, so we were able to resupply them, which was a good situation. So yes, we are partnering, and it's kind of a growing relationship, and but I think it's been good for both parties.
Great, thank you, Abe. One thing I will mention, a lot of different tribal partners have picked this up and are doing naloxone in many different ways. One of the things that is important to think about is that the Good Samaritan law, which, just to remind folks, in 2010, along with the naloxone law, was a Good Samaritan overdose law that provides immunity to a person who has an overdose or seeks medical aid during an overdose for simple drug possession charges. But of course, that doesn't apply on tribal land. So that's really important just to be mindful of. I have seen some tribes who've said, you know what, we want to make this de facto policy. And it's interesting, in order to do that, if you choose to, as a smaller community, you pretty much get the stakeholders together in a room, you make that decision, you let everybody know. You might do an op-ed or start putting brochures together or whatever it is, just to spread the word out. And then you haven't had to go through the process of establishing a law, but you've made your policy known. And that's very important, obviously, to have folks like a chief of police and prosecutors and maybe elected officials and a health officer, those types of folks involved in that. So again, we are all out of time. This has been wonderful. I really want to thank presenters, Abe and David and Kurt, and thank everybody for your questions. And I really want to give a huge shout out to Allison Newman, who put all this together, and you see her contact information here. So thank you very much, and really appreciate your input. Would appreciate any follow-up feedback you have for us about next topics you'd like to hear about. And that's it. Thank you very much, and have a good afternoon.